Hey guys, and this is the best Christmas present I could have ever asked for. This is the amazing Dr. Stephen Fox. He wrote this. Oh my God. Okay, so I bought this many years ago and I was just absolutely blown away. And I've been chasing him ever since. And here he is. Please, Stephen, tell us about yourself so everybody can be as wowed.
Good day, Hannah, and good day, those of you who have joined us. I'm in a situation here in the middle of America, literally in the geographic center, north to south, east to west, and I'm looking out my window at about 5 inches of fresh snow. But rather than look into this webcam, I have a large view television just to my left, so I'm going to turn my head and go dark from you, but this is as good as it gets. And I look forward to visiting with you and together with Hannah over the next given time. So thank you so very much for the privilege of your time.
No worries at all. So what we're going to do tonight, guys, because this is just such a big opportunity for me, is we're going to start off by talking about the pathophysiology of OA. So what does that mean? It means getting down dirty at what actually is happening within the joint. And my honest belief, and that of Stephen, is if you can understand how complex what is happening within the joint is, then you're going to be able to understand how the interventions are going to work better. So I'm going to share a screen and then Stephen is going to talk us through. So 1 minute, guys. Here we go. There you go. So over to you, Stephen. You carry on talking and just tell me when you want me to change slide.
All right. Well, to build on Hannah's point about the complexity of osteoarthritis, let me just start with the complexity of the nervous system. You know, the first impression that one gets when they look at the nervous system is how simple it is. I mean, it's just from transduction to transmission, modulation, and then perception. I mean, how easy can it be? Well, then when you look a little bit differently, your second impression is its complexity. And I think that it was Einstein that once said something to the effect that you can make things simple, but only so much so before you start to lose meaning. And I saw a documentary recently where it was brought to my attention that the human brain has something like about 87 billion neurons and yet 100 trillion synapses. And so you have this counterposition, if you will, that it's simplistic, but it's also very complex. Well, with that said, let's look at this circle of inflammation, and sometimes referred as a vicious cycle of inflammation. And it is cyclic in terms of understanding and appreciation. So let's just start at the very top. And for reasons of space, you could say instability, or you could put a number of other etiologies that initiates synovitis. And so I just said it could be trauma. It could be of an iatrogenic origin, which means that it could be self-inflicted, or it could just be some kind of instability. But regardless, the insult, and that insult typically is one of three etiologies. It's either mechanical, or it's chemical, or it's thermal. So typically with one of those, pick your choice, there is initiated within the joint a synovitis. And the ITIS, as you were taught way back in first year of veterinary school, refers to inflammation. And that's exactly what happens. You get an inflammation of the synovial intima, and that's the lining of the synovial joint. And that lining typically is about 2 to 3 cells thick. However, following the start of synovitis, you get an overproduction of the cell type macrophages and synoviocytes. It includes synovial hyperplasia. So this is not only a hypertrophy, but it's a hyperplasia. So you get an increase in cell numbers and an increase in cell types. Now with that comes an angiogenesis, which is an increase in vascularization. So with my poor artistic work in the upper right-hand corner, you see what was meant to be a cross-section of the synovial joint with a thin synovial intima to a thickened synovial intima. And that's the best I can do with Photoshop, so I'm sorry with that. But after you have this overproduction of the macrophages and synoviocytes, and incidentally, you have two types of synoviocytes in that lining, synoviocyte types A and B. Synoviocyte types A are almost all macrophages, and synovial type B include fibroblasts and other cells that produce such things as high hyaluronic acid and leucin and so forth. However, now we're going to dwell on macrophages, so don't throw back at me. Don't give me one of those big old...
Tell me what a macrophage is, because a lot of people are going, whoa, this is quite complex. So synovium's the joint lining, guys, where you always think about the joint and the cartilage. So we're talking about the joint lining. And then the synoviocytes are actually cells within the joint lining. And there's different kinds of synoviocytes because they have kind of different roles. So what Stephen's really alluding to here and trying to step you away from is thinking about it being a abnormal joint shape. We want you to stop thinking about arthritis as just being a mechanical disease with abnormal bone on abnormal bone and the cartilage degenerating. We want you to start thinking of it as more as an inflammatory disease. Carry on, Stephen.
Well, that's exactly right. In that for years and years, we've always tend to think of osteoarthritis as a disease of cartilage. It's a disease of the entire joint, and there's a considerable interplay of a lot of different cell types and tissue types, and we're going to cross that border here, that bridge, as we go around this circle. But you're absolutely right. It's the inflammation within this joint that causes subsequently the destruction of the cartilage. So we're talking not so much about the start of the disease with cartilage, but the start of the disease with inflammation. And that's first noticed in the lining of the joint. And so as we move then down to about the 3 or 4 o'clock position, we get recruitment of these macrophage cell types and their overproduction. Now, these macrophages are by some considered to be the future of pain management. They play that much of an important role in the disease situation. So now we take a look down in the bottom right-hand corner, and this looks like it's a sophisticated diagram, and it is until we explain it. And so you can see by the very bottom nomenclature, what we're looking at is a cross-section of the joint, and on the far left is represented cartilage, and you would know that the cell types in cartilage are chondrocytes. So those chondrocytes create certain types of subcell types. And then you move on to the right, the joint space, and we got a whole lot of what looks like Chinese graphics in there. And those are the nomenclatures of the different inflammatory mediators. And those inflammatory mediators we term cytokines. There are cytokines and there are chemokines, but basically they're all inflammatory mediators. And then to the far right, as we have just started to talk about, we're talking about the synovial lining. And in the upper part of the right-hand side of that graphic, we see the fibroblasts, and those are synovial type cell Bs. And then in the bottom, we have the macrophages, and those are synoviocyte type A, which are mostly macrophages. So with all that gobbledygook that I just gave you, the important point about this diagram is that there is significant so-called crosstalk. So information comes from these cytokines and chemokines that are in the synovia, and they find their way mixed into that synovial fluid and then back on the cartilage, and vice versa. From the cartilage into the synovial fluid, mixing there, it's a big milieu or soup of all these inflammatory mediators that then have an impact on the synovial lining. So there's a back and forth crosstalk all the time with these inflammatory mediators, again termed collectively as cytokines. Now we go to the 6 o'clock position down there where you see that hand squeezing the sponge. Now, what's happening here is that these inflammatory mediators are moving in and out of those tissue types, the tissue types being the synovial lining and the cartilage. And so when you weight bear, you or the dog, you're putting pressure on this joint. So you're forcing all these inflammatory mediators from that synovial fluid into the tissue of the synovial lining and into the cartilage. Then, when you let your weight off of that limb, it causes a relative vacuum in that synovial space. And now it sucks back into that synovial fluid all of those inflammatory mediators that you just forced into both the cartilage and the lining of the joint. And so these inflammatory mediators move back and forth, creating more and more of lookalikes to themselves. And within the cartilage, you start now to get degradation. So you see it about the 7 to 8 o'clock position, that is erosions, little Grand Canyon erosions in the cartilage, because many of these inflammatory mediators actually cause destruction of the cartilage. And so as much as wear and tear, but even more so resulting from these destructive cytokines, the cartilage starts to degrade. And then that initiates and drives this cartilage destruction, which is contributing to the chronic pain. Because as you know, and we go back to, is this a disease of cartilage or of the total joint? Well, cartilage has no nerves in it. So the pain that you feel, the pain that the animal feels, does not come from the degradation of the cartilage, but it comes from being triggered by these inflammatory mediators. Although there's no nerves in the cartilage, in the subchondral bone that's right below that cartilage, that tissue is quite robust with afferent or signaling nerves, as are the menisci and the joint capsule and the synovia. So the animal now is very painful because they are continually having the nerves that enter their joint being activated. And the worse it gets, the worse it gets. So we get the cycle started. And then the real question at hand is, how do we get something involved that suppresses this progressive cycle of inflammation?
And I think that's really, it's such an important take-home message, guys, because I know a lot of you read online and, you know, you're looking at maybe, dare I say, a supplement, a nutraceutical or therapy, something that you want to add to your dog's treatment plan. And there's a real focus on cartilage. And I just want you to step away from that for a bit and realize that actually it's way more complicated than just that. And something else we were talking about earlier before we went live is that being able to classify arthritis into mild, moderate or severe is actually very difficult because, and I'll let Stephen explain because he explained it so well earlier.
Well, Hannah, yes, to now after Hannah hears me say this about the 5th time, she'll be convicted or convinced of its credibility. But years ago, I was involved with a couple of very successful NSAID launching, and they put a stake in the sand saying, listen, we can divide the patients into mild, moderate, and severe pain or osteoarthritis. And I never really supported that logic. Reason being is that because animals are non-speaking, and let me just back up and give you something to put in your memory banks, is that pain in humans is what the patient says it is. Pain in veterinary patients is what the observer says it is. And so it is that I believe that by the time an animal feels uncomfortable, painful, early pain, it's like when you walk with a blister. You go through a period of time before you start limping, and you go and you say to yourself, ouch, that hurts. And then pretty soon it gets worse and it gets worse and you start to become lame. Well, now that, if it were the pet that we were assessing, is the first time that an external observer would say, hey, I see you're limping. You must be in pain. And so if we go back to this mild, moderate, and severe, my contention is that we don't see animals as lame until they show us they've got some lameness. It could be in their disposition, manifestation, or manifested in their disposition. They become grouchy and so forth. But basically, we don't think we see pain in them until they show us something. My contention is that none of us, ourselves or our pets, show that in the very early stages. So I say we don't see mild. I'd say by the time we see an expression of pain, they're in at least the moderate stage.
I think, and another person that really supports that statement is the amazing Dr. Chris Sink, who is countless times has said that dogs don't tend to show pain until they're 6 out of 10, 7 out of 10, 8 out of 10 bad. Trying to decipher whether a dog is in pain from 1 to 5 is actually quite difficult because they are so good at coping and they're so good at getting on with life. And I think that's something to really take home. And the reason I say that is because I think people think I'm a bit crazy being obsessed about arthritis and wanting people to take it seriously. So when somebody says, oh, he's just got mild arthritis, I'm sitting there going, no, this is an opportunity where you can really influence it. Don't just sit back and go, oh, it's only mild, I don't need to worry about it yet. This is a time where you need to be putting changes in place because the arthritis by that point is pretty well established. So don't write it off saying it's just mild. There you go.
Well, yeah, and I would add another point to that, Hannah, which is that as veterinarians, we oftentimes are only seeing this pet in a snapshot of time, whereas the owner is seeing this patient on a continuum. Mm-hmm. And I think that many times as veterinarians, we underplay the history-taking component of early diagnostics. We bring the dog in to see the veterinarian, and he looks fine. The veterinarian says, okay, well, I see him running around the exam table here, looks fine to me. What is occurring is that at home, the dog knows it gets a little bit of sympathy when it's gimping around, and so it expresses its normal feelings, which is painful. Now he goes to the veterinarian, he's all excited, it's a foreign area, there's all kinds of strange noises and smells and so forth. They are distracted. And so they're not focusing on their discomfort unless it's real severe. And so it is that oftentimes we go, man, I was embarrassed. I took my dog to the veterinarian for his lameness and he wasn't lame at all. As soon as I got him back home, he's lame again.
Yeah. Totally. And that's why, guys, you should really think about trying to give your vet as much information of what you see and what you've observed and the frequency of your observations. And hopefully one of the Canbassadors will be listening and they'll put up a couple of resources that we've made for you to just download for free. There's one about how to take good videos of your dog. So we'll put a PDF up here so you can learn how to take good video footage for your vet to have a look at. And we've also got a questionnaire that you can choose to print off and you can fill in your own time and take it with you to the vet. So they've got more to work on because us vets do struggle. We've got 10 to 15 minutes in a little cubicle room with a big table in the middle of the room. We've got a lot of pressure going on around us. We also have to write up your notes, prescribe, go get the drugs, fill in the invoice. It's a lot to do in a short period of time. So coming with lots of information is really, really important. All right. Shall I go on to the next slide? It gets even.
Now we get to Einstein. Yeah. Well, toward that example of what Einstein says about it, you try to make things simple, but only so much so. I throw this at you not to overwhelm you, but to give you an appreciation of the complexity and why finding a resolution, a consistent, effective resolution to osteoarthritis is an absolute challenge. And so what we have is in the upper part of the slide, we see on the left, the arthritic joint with a lot of the red, which is depicting inflammation, abnormalities, and so forth, contrasted to the right-hand side of that, which is more normalcy. And then we get down to the big picture down here in this graphic. And I would call your attention to that box that says pro-inflammatory mediators. Now, this is where the scientists have their field day, because we have these cytokines. Now, these are a group, collectively, the term is cytokines. It includes all of these things like interleukins and tumor necrosing factor and so forth, and MMPs, matrix metalloproteinases. I mean, it's about all you can do to get your tongue to get.
Oh, it's terrifying. When you read these sections in textbooks, you just think, I'm never going to remember this, ever.
That's right. And so the point is that all of these play a different role, and they can play a synergistic role, or they can all play on one another and cause a greater problem than the addition of just one to the other. So they can work synergistically. They can create themselves over and over. They can work to make some other of their like kind very complex. And so then when one says, okay, well, how do we address this? What is occurring in the world of R&D, research and development, is there are hundreds, if not thousands, of scientists who are looking at each one of these individual proteins and have spent maybe a lifetime studying them and trying to ascertain whether or not that is the golden chalice in terms of trying to resolve or exacerbate osteoarthritis. And then a final point I would make on this slide is in the bottom right-hand corner over there, you see that term macrophage. And that macrophage plays a strategic role in forming this osteophyte. So to the left of that macrophage term, you see that kind of finger, which is meant to represent subchondral bone. That's bone that's right under cartilage. And oftentimes, even if you have like a bone spur, that's what in layman's terms, a bone spur would be that your physician might suggest you have in some joint. So it's all of these together that work in mysterious ways that we're trying to sort out and see if we can't find something that takes us most directly to resolution of the problem.
Yeah, and I think for me, like things really good take homes for owners is in the pink box. There's a word adipokines. Now, here comes obesity, and we keep talking about weight control, weight control, weight control, and you guys are going, yeah, it's just mechanical weight carriage. It's not. It's really not, and we know that weight loss doesn't have a linear kind of pain relieving response. It's almost exponential. So we know that losing weight isn't just about the mechanical load on these painful joints. It's also about these inflammatory mediators, which are basically exacerbating the condition. And again, we don't want to do this to terrify you, and I hope you're all still listening in. I wanted to do it to make you realize how complex it is, but also for you to be excited that there are so many different things that are being developed to try and control arthritis, because it's so prevalent in our dogs. It's such a common disease, and it can feel a little bit demoralizing thinking that we don't have many tools in our toolbox, and we always just talk about maybe anti-inflammatories, just weight loss. But actually, these slides really start to show all of these intervention points, which hopefully we'll be able to get a chance to talk about a few of them. I'm just looking at the next slide. Whoa, I think we're going to step out here.
No, let's not.
Let's stay.
No, it says no.
Okay,
I think the point to be illustrated in this slide is not that you're reading this. The point is that in the bottom left, under molecular, you're seeing a list of many of these cytokines that I've already mentioned, but you can see that it's a bigger bag than just what I've mentioned. And so the point here is once again restating the point that Hannah has made. There are many, many, many contributors to this total disease condition. And sometimes we don't appreciate it until we actually see it in print, like we do here, right in front of your eyes, where you can say, oh my goodness, he's absolutely right. Look at all that gibberish. It is complex. Okay.
Okay, now, so what we're going to do is I'm going to just step out. I'm going to stop sharing. Back over here. Right, so because Stephen's looking at another screen, he's not going to be facing us, so he's going to keep black screen. But what I do also want to spend a little bit of time talking about is peripheral and central sensitization, because I think a lot of people really don't understand about the pain of OA. And I think, well, I have definitely found when I've been doing owner workshops or vet lectures, nurse lectures, when I start talking about the potential of central sensitization, people sit back and go, right, this is a disease to be taken seriously. So can you please explain to the guys what that all means?
Well, let me start with Einstein. You can make something simple. I like, in simplistic terms, I like to convey the mental concept that you're basically looking at a tree. And you can think of the trunk of the tree as the central nervous system. And you can think of all the branches and the leaves as the peripheral nerves. And so again, I have mentioned it in that cycle of inflammation, or that cycle of inflammation, that to get the nervous system to really wake up, you have to have an insult that's conveyed in that nervous system. And when we say insult, is either chemical, mechanical, or thermal. That initiates a receptor at the end of a so-called afferent nerve. And afferent refers to the fact that that nerve takes information from the periphery more toward the center of the nervous system. And that would be your spinal cord that sits in the channel that's created by your backbone. And so what happens is that as this insult, be it thermal, chemical, or mechanical, starts to transfer information to the trunk of the tree, that's your spinal cord, it goes through many, many intersections, just like going through traffic lights and roads that come together, in this case, limbs on the tree. In so doing, you run into more and more complexities, and cell types that transmit information now start to talk to one another. And we call that crosstalk within the nervous system. And by and large, once this information comes to the spinal cord, it's changed. And so it goes through different levels or depth, if you will, of the spinal cord. Those nerves that are most toward the outside of the spinal cord control different things of your body than those that are more on the inside of the spinal cord. And once you start to get painful inputs, not only is that information transmitted, but it's acted upon, such that the pain can actually be at such a point or changed so much, and we call that central sensitization, that it is no longer what is coming in. It's something that has been changed as it now moves forward. And I say forward in that it moves up to your brain so that you now can cognitively interpret it, the information. Now, a point here, people talk about pain, and one might think, well, when you're under anesthesia, can you be painful or can you not? By definition, you will not feel pain because you have to cognitively, and that means consciously, be able to interpret the signals that are coming through your spinal cord and that pain pathway. You have to be able to consciously process, or it is now a different term called nociception. And so it is that when you're under anesthesia, do you feel pain? No, because you do not have the ability to be conscious and therefore process that signaling, but you do have nociception. So once you come out of your state of anesthesia, boom, now you're painful. Same signals that have been coming, but now you're cognitively processing those as pain. So there is a differentiation there. And in most simplistic terms, that's what occurs. And you can have a phenomena where you have peripheral sensitization, and that is where the insult, again, being mechanical, chemical, or thermal, is greater than you can manage. And in that case, we'd call that, say, hyperplasia or an accentuation, hypersensitization of peripheral input. And then once that phenomena occurs in your spinal cord, now you have a central sensitization. And when those phenomena occur, your body is no longer responsive to most of the routine drugs that we use.
Nailed it. That's exactly what I wanted you to say, because there is this real belief that OA management is simple. It's simple. Oh, they've got arthritis. There you go. It's a pill. No. What we're trying to get across to you guys is it's really complex of all the different things that come together and the progress, but also it doesn't stay within the joints. Yes, we really do have to start considering what effect arthritis is having on the nervous system. And this can be really well illustrated when you have a young dog, for example, who hasn't got the Lord of the Rings joint. It's not gnarly, hasn't got loads of bone spurs, isn't hugely swollen and inflamed, but they're still ridiculously painful. And you sit there thinking to yourself, well, how can that be? Because that arthritis can't be that bad. You know, I've still got range of motion. I haven't got gross remodeling, but this dog is really painful. And I think we need to have a much greater appreciation that this isn't a disease just of the joint. And we have to look at the other tissues that get drawn into the party. And many people will say that once central sensitization is taking hold, you've got two diseases, as Stephen was saying. And that second disease, which is budded away and it's become its own entity, doesn't like the same drugs that arthritis likes. We have to start thinking differently. And this is why when you go back to your vet and you say, well, this anti-inflammatory is not working, well, actually, that could well be that your dog's arthritis is now more centrally sensitized, more, we need to have more consideration to the nervous system changes that have taken place, and we need to use adjunct medication. And people get really scared of that. They start thinking multiple pills is a disaster. Oh my God. No, it is not. You are accessing different points in what's called the pathology. You're targeting the joint, you're targeting the nervous system, you're getting your lifestyle in shape, you're getting your weight control. All of these things play a really big role. And my real aim tonight was to try and start showing people that it isn't simple. And that's why there are a complex array of interventions that people can employ. And that's what we're going to go on to now. So I really stitched him up, actually, because I've now got the title of What Works and Why. And we're going to just try and run through a few. We're going to stick no more than, say, 5-10 minutes on each one. But again, the intention is to give you guys a better understanding when managing your own dog's disease, that the path might be a little bit windy. It's not going to be a case that you're going to get prescribed pill A and then it's all going to be okay. It might be that pill A, the dose needs adjusting. We might need to give it more time. We need to add pill B, maybe even pill C as well. We need to bring in some multimodal interventions alongside it to give it a chance to work. OA management is complex. It's really complex. And the people that do it and do it well, they put a lot of time and thought into how to make the best. So let's start with a foundational intervention, which is the non-steroidals and piprants. Where are they working in this situation? We've got the joint and we've got the nervous system. Where do these drugs have their role?
Well, let me up and expand on a point that Hannah was making, which is if you're talking to your veterinarian or your physician as well, and you presume they're giving you the pain pill. Now, you've already witnessed how complex pain is. So when you say, what is actually in this pain pill and where does it work? And well, you've already seen this whole milieu of cytokines, which are different proteins that act in different ways in different systems. Not only in your body system, but different systems. There could be a serotonin system, there could be an arachidonic acid system or pathway. And it's that a lifetime of work, maybe decades, are represented in that tablet or that pill. Maybe it blocks MMP2. That's what that pill does. Now you say, and that's going to do it all? And the answer is no, it may not do it all. That's why this is so complex and brings to mind then a so multimodal approach to managing osteoarthritis. And I think that, I'm not sure I'm answering your question yet, Hannah, but I think it's an important foundation, which is that there is this concept of so-called synergism. Synergism means that you can give one agent together with a different agent and get a better response than you would have anticipated. So in this case, for example, 1 + 2 no longer equals 3, 1 + 2 = 5. And so there are drugs that work synergistically in that regard. If you use them together, you'll get a lot better response than if you just use only one. And particularly, let's say with opioids, you would know opioids, morphine would be a term probably familiar to you. If you can suppress a certain amount of pain with morphine, but you cannot continue to give more and more and more for increasing amount of pain because, of course, you have these adverse responses up to death in those circumstances. So how can we continue to use, let's say, morphine and not have as much of that side effect? Well, what we do is we use it together with another drug or modality. The point being that each one of these treatment modalities, and they can be, I say modalities because I'm going to give you a couple of examples that are not drugs, but they're different approaches. And so if you're using a drug that gives you this synergism, that will allow you to take either one of those drugs and use a smaller and smaller amount because together they give a more powerful response. And that's the whole concept of multimodal approach, is if you use different approaches with different drugs, they have a different mode of action. And hopefully at this point, you've already appreciated that there's lots of mode of actions going on here with all of these different proteins and funky names. And so if you give multiple targets, then you will require less of something that has a potential bad effect than you would previously.
Yeah.
Now we can.
I think a really good illustration of that, guys, in the most simplistic manner is if your dog has been prescribed a non-steroidal, then let's get the dog's weight off to reduce those adipokines, which are in that inflammatory soup that's aggravating and progressing the arthritis. That is a multimodal approach. It's in the most simplistic approach. Another thing to think about, that non-steroidal is trying to work really hard, but if you keep throwing that ball and that dog is putting those joints through a range of motion and stretching through that highly innervated, aggravated joint capsule again and again and again, that non-steroidal is going to be going, I'm really trying. I'm really, really trying, but you're not helping me here. So that complexity needs to be respected, and that's where these multimodal comes in. Use multiple things at the same time to get the best effect. And that doesn't just mean things that you pop in the mouth. That's different interventions, even weight control and lifestyle change.
Exactly. So that's why I said it wasn't only medications or pharmacologics, but it also such things as diet and exercise, weight control. There was a nice study that was done about 15 years ago now, where they took litters of black labs and they split the litters, and one part of the litter was given so-called ad lib, which was they could eat all they want. And then the next day they would give the other half of the litter 3/4 of what their litter mates ate the day before. So we had half of the litters that was eating all they wanted, the other half of the litter that was only eating roughly 75% of that. At the end of life, they showed that the difference in presence of osteoarthritis was 50% for the reduced fed and 80% for the ad lib percent. And so a huge difference just in the caloric intake. Further, the dogs that had the reduced caloric intake lived 1.5 to 2 years longer. So that's just caloric intake. But if you further then look at diet and you say, well, what if you fed some of these fatty acids? Okay. Now, Hills of Pet Nutrition has substantiated in exhaustive studies that showed, for example, if you feed your dog some of these osteoarthritis reduction diets, and all diets have different nomenclature for what they call that. But basically, if you were substituting omega-6 fatty acids, then you would reduce the amount of, in this case, in their study, they looked at Rimadyl. You could reduce the amount of Rimadyl by 25% because the metabolism of these N6 fatty acids is different than arachidonic acid, which makes up most of your cell types. And as they're metabolized, one goes to an inflammatory prostaglandin, the other goes to a far less inflammatory prostaglandin. So you see, now we're starting to collate different modalities to include diet, type of diet, caloric intake versus the kind of fatty acids that are being metabolized, together with the kinds of drugs we're using. The kinds of exercises we take are also integrated.
Well, I'm glad that you mentioned Hills, because there's such a nutrition war. It's a really emotive topic, and I don't want to get into what you should and shouldn't do. But I do want to give acknowledgement to Hills for this amazing diet that they've created and the huge amount of studies and strong clinical trials that they did to prove that omega-3 fatty acids in a good ratio with omega-6 can have a superb influence on pain state. And for people like me who are ridiculously busy, for having that medication in a bag, convenient to give with weight guidelines, is really, really brilliant. And I use it a lot as a vet, because not only does the diet offer me lots of advice about how much to feed to get the right omega-3 fatty acid intake, but also the right calorie intake as well. So just, heads up to Hills, well done. And something you guys should know, that we talk a lot about omega-3 fatty acids. And something that I find quite sad when I see it on Holly's Army, and you feel like you're always being the party pooper. But when people say, well, I give omega-3 fatty acids, there is a certain amount that you need to give for it to be clinically beneficial. So when you see these treats on the market, so you go into the supermarket and good for joint health, it's got omega-3 fatty acid in it, that doesn't necessarily mean it's going to be therapeutic. So there's a lot of, there's a wide range of how much it should be, anywhere between 100 milligrams per kilogram up to 300 milligrams per kilogram. That high end of the spectrum is likely to cause diarrhea if you add it in addition to the diet. So these diets that incorporate them into the diet have balanced that out to try and minimize any gastric upset. So just bear that in mind, because these packets of treats with joint health written on them do frustrate me. We're gonna stay in supplements and nutraceuticals, and we're going to talk about something that Stephen wrote years ago and it's been used globally. I've seen it in so many lectures, and it's called the Acclaim. Do you want to explain why you did that?
Again, what was the question?
With
Explain.
the Acclaim, why did you come up with Acclaim? I saw it and I thought, oh my God, you've answered all my worries, because I was trying to write the supplement section for my website, and I was just finding it hard work, because what's within the clinical trials doesn't mean it's the same product that someone's going to buy off the shelf. So we might be able to say to somebody, hey, omega-3 fatty acids, really very good. But when that owner goes to a shop and they purchase something, it doesn't mean that it's necessarily that good. And when I found Acclaim, I was like, oh, the answer. So was it the same for you, or, and I'll go through Acclaim in a minute.
Well, we're talking nutraceuticals now, correct? Yeah. Keep in mind that nutraceuticals are a food additive. They're not a drug. And no one is rigid in their policing the nutraceutical business. And so as part of claiming yourself to be in commerce with a nutraceutical, you are not allowed to make claims. Therefore, you will find all the nomenclature on advertisements for these kinds of products as saying it may do this, it may do that, reason to believe it'll do this, and so forth. And as a matter of fact, from one of your broadcasts, Hannah, you will recall Duncan LaSalle stating a point which I thought was exceedingly well taken, and this had to do with red wine. And resveratrol, which is a component of red wine. If you're into that, you may not be. But the point was that resveratrol, which is a component of red wine, has in fact been recognized to have health benefits, provided that you're consuming greater than 500 milligrams a day. Now, roughly, you get 12.6 milligrams per liter out of red wine, which simply means that you only have to consume 40 liters to take advantage of that health benefit. However,
A day.
That's right, a day. And so it is with many of these nutraceuticals. It's far more than what the component or the active component is. And that's part in your criteria of judgment of whether or not you might want to use these kinds of agents, because so much of it is, okay, how much of the product do you need per day? And how is it processed? And is there a label that gives you some indication of how much a day you should be administering, a dose rate? If a label on a product does not give you a dose rate, then think twice about whether or not it has any value, because what they're taking advantage of is a component, perhaps, that's in this jar or bottle that may have some helpful feature in some way, but unless it can be validated, then it's just somebody else's opinion that's marketing the product. And I often say the most expensive products for treating osteoarthritis are those that don't work. It's almost like,
and that's a big side effect profile as well. If you're treating pain and the product you've actually chosen to use does nothing for the pain, as far as I'm concerned, that's an adverse event because the animal is still in pain. So yeah, just be wise. I'm going to read Acclaim very quickly. So basically, Acclaim stands for a name that you recognize. So we want to use products that have a well-known manufacturer, because there's a lot popping up. We see them online. The Cambassadors are on this all the time, seeing new supplements that are being very well marketed online. Clinical experience. Has the company got any, are they making any attempts to substantiate their product? So if they really seem to just be on the bandwagon of selling it, they probably are on the bandwagon of selling it. Content, are all the ingredients clearly put on the label so that you know exactly what you should be getting? Label claims. Now, this is a biggie for me. If there are some really good marketing antics going on suggesting 100% improvement guaranteed, rid your dog of all their pain, cures arthritis, sets back the disease, slows it, all these things. No, just no, because they're wildly going too far. It's just not possible. Administration recommendations need to be really clear. So we want to know how much of that product we should be given per weight category. And really important, identification. Can that product be traced? Have we got good manufacturing processes going on here? And we want manufacturer information. So we want to know more about the product. So that's just a little bit of a guide that I hope you guys will use, because as said, we've seen supplements come and go in the last 5 years that CAM's been running, and they come online in a real big ball of marketing. And they're like, yes, we're the UK's best selling supplement. Well, you can't be, because you only launched your company in February, so that's just not possible. But loads of them have come and gone, even in the short time CAM has been about. We don't want you to fall for the trickery. Please talk to your vets. Please get advice before spending what is a substantial amount of money. Do you want to add to that, Stephen?
Well, again, historically, glucosamine and chondroitin products have been put out on the shelf for consumption in just a plethora of offerings. And so I think that if you are an individual who thinks that you want to investigate that, or you might think it's appropriate for your pet, I would have a consultation with your veterinarian to include such things as what dose is appropriate, actually what salts are the products presented in. That doesn't mean literally, as it may sound to the layperson, but for example, glucosamine is a common product in nutraceuticals for joint health. Now, glucosamine can come in a hydrochloride, so-called scientific salt, hydrochloride, glucosamine hydrochloride, or it can be made available as a sulfate salt. So you could have glucosamine sulfate. Is there a difference? The literature would suggest there is. Same is true of chondroitin. Chondroitin sulfate, or is it in a different salt? So it would behoove you to look into this, maybe on the internet, ask your veterinarian, ask your physician if you're taking those same kinds of supplements. And then there's just endless of these supplements, boswellia, I mean, just endless copper, all of these things that basically lack that scientific base and do not meet the criteria of this acclaim acronym.
Yeah. And I think a lovely little kind of story of the past for me, which I've told before, hopefully will hit home with a couple of people. I went to a pensioner's house to look at her dog, who she had contacted me because I'd left one of my flyers in a pet shop and she'd found out about me. So I went round to go and talk to her about her dog. And this dog was in a lot of discomfort. I would have said he was centrally sensitized. And the lady was spending a fortune on supplements. There were at least 4 that she brought out and put on the kitchen table, all from different pet shops, online, wherever they were sourced from. And none of them had any strength to deal with the condition she had in front of her. That dog needed medication. And that money that she was spending every month on 4 supplements was better invested in actually having a checkup with a vet and getting something that we've got clinical evidence is going to work. But this happens a lot. It really does. So if at Christmas you're going to your family's house, a friend's house, or you're meeting up with someone and you can see that someone is going down this pathway where they've obviously got a dog that needs an intervention, and you can see that that person is looking in the newspaper, looking online, going to the pet shop, and they're amassing an array of interventions, just go, stop, just stop. You know, speak to your vet. There is potentially a better way to this. Perfect. I did kind of prep you for this intervention. So we're going to leave non-steroidals and pit prance. We're going to talk about intra-articulars. And then we're going to follow on with something new and exciting, which Stephen knows a lot about. But let's just go into the world of not giving something by pill, because we've got our supplements by pill, we've got our medications by pill or liquid. Now let's talk about actually dealing with the original focus, the joint. Explain that. You know, we've got the hyaluronic acid, steroids, PRP, stem cells, etc.
Sure. To build on the groundwork that Hannah just laid is think about taking a pill. A pill has to go through your digestive system. Your digestive system is designed to break up big molecules into little molecules to be absorbed in the bloodstream and then carried to some part of the anatomy where it needs to be administered. So it is that there are a lot of medications that just cannot be designed to reach the target tissue because they're going to be destroyed in the gut. Mm-hmm. And therefore, we have to look at other means of getting to the target tissue. And now when we're talking about the joint, of course, it just makes sense that a way to address some of these inflammatory mediators that we've been presented with in this discussion, how do you get to those? Well, the best way to get to it is to introduce an agent right into the joints into the joint with a needle. Mm. And so it is that we have agents such as hyaluronic acid, which is an agent which is kind of a lubricant for the joint. Sometimes that there's a deficiency of that within the joint, and so we supplement it. In most simplistic terms, we have stem cells that some believe are advantageous to help repair tissues within the joint. The jury is still out on whether or not that is only conceptual or is really therapeutic. Same is true with PRP, and sometimes those are used together. And so for years, we have thought about joint OA being a mechanical problem that is a cartilage problem. And I think we're at a magnificent point in science advancement in recognizing that the microenvironment, which is to say the microscopic level of what's going on in the joint, is getting our attention in terms of addressing how to mitigate the propagation of osteoarthritis. Mm-hmm. And part of the reason why we've not been advancing in this area before is because a lot of the technology that is now new over the last 15 to 20 years is available in the laboratory to be further studied and applied clinically. And so it is that we have now other options to add to this multimodal approach. And whereas, for example, myself, trained as an orthopedist, I would go to professional meetings, and almost all of the lectures that were presented were on how to better stabilize in terms of mechanical structure the joint or some abnormality of the joint, say misalignment or stabilization process or something like that. Either teaching you a new procedure to stabilize something or a fine-tuning of something that's been around and you were taught in veterinary school when you were going through as a student. Now we're opening that door to say beyond that, what do we do to change the microenvironment of the joint to make it more like it should be, more natural? Mm-hmm. And I think that that's where we are. And
I heard, just to butt in, I heard a fantastic debate between John Innes and Duncan Lascelles. And it was...
Those two would do it.
It was kind of like two men in the armchairs just having a bit of a debate, a little bit of a pokey, and a little bit of a mick take out of each other. It was good. It was really good. And they said exactly that, you know. John Innes was saying to Duncan Lascelles, okay, I concede the inflammatory molecular level of the joint has a massive influence on pain states. Potentially, it's been ignored for the pursuit of stability. So orthopedic surgeries that try and make that joint function better. so there's less trauma. So those have been the mainstay. And there's obviously in the past, Duncan and John over maybe a red wine have been debating whether the inflammatory state of the joint needs to be taken more seriously. And I think that John conceded during that interview. It was really, really good fun. So do you want me to share your slides again? Because what we'll do, we've hit an hour. Why don't we just leave the followers on what you've been up to for the last few years, because it's not going to be available in this country for a while. I don't know the legalities of it, but when I heard about it a few years back, I was blown away. I was just like, what? And for me, it's going to really excite the profession. I think it's really going to excite owners that a lot of advances are being made. For people that wanted to know about monoclonal antibodies, I promise I'll do them in another Facebook Live. So in the last few years, we've got PIP-RANTs arrive, monoclonal antibodies, and other therapeutic interventions like shockwave. Now let's introduce you to something else. I'm going to share the screen again for you.
And let me add to a door that you opened, which was about surgeries for stabilization. One needs to keep in mind that when you do surgery, you are initiating inflammation. Therefore, if you are focusing only on enhancing stabilization, at the same time, appreciate that you are inciting a certain level of inflammation, and then you just simply are kicking that can down the road if you're not going to subsequently address the pain from that inflammation.
Yeah, no, exactly. And I think a lot of people assume that surgery is just going to fix the problem. The dog will recover and it will all be fine. But as you say, if there's an OA situation already in place, that has got to be managed. So for any people that are having a TPLO surgery, a TTA, any kind of cruciate surgery, you still will have an arthritic joint to contend with. Yes, it should be better, but it's still an arthritic joint. The only way that you get rid of arthritis is to remove said joint, like in a hip replacement. But then you've got to remember that that's quite often a bilateral condition. So what's happening with the other hip? What's happening to other joints? So just do remember that. Is this a good slide for you to start on, or would you like me to go elsewhere?
No, that looks fine.
Good.
So to make a couple of points, we do have drugs that are designed, actually, they were initiated for long-term use, and then, for short-term use, and that would include such drugs that we're familiar with, like opioids and non-steroidal anti-inflammatories. There are abbreviated disease-modifying osteoarthritic agents. Those would also fall under the umbrella of nutraceuticals. And then, of course, we have Galliprant. That is, some consider them to be NSAIDs, but they're actually not in the same class. In 2013, the World Health Organization brought those products out that are different. They work by a different mode of action than do NSAIDs. So anyway, it is inappropriate to think that you're going to have good control of chronic pain if you're using drugs that were designed for acute pain. And of course, we talked briefly about surgery, but that's in a further camp unto itself. But we really have this gap. And if you were going to go home and design the ideal agent to treat osteoarthritis, what features would it have? Well, you'd want it to be long-lasting. You'd want it to be easy to administer, compatible with other drugs or agents, because we already talked about this multimodal concept by using drugs that work best together, that you want something coming to the market new that will work with other drugs. You'd prefer it to be non-opioid for a variety of reasons. And now the move in medicine is to try to get away from opioids. You would like to have the product readily available and have monetary value. Now I use value, not price. There can be a very big difference. Again, the most expensive products are those that don't work. And then you'd like to have credibility from the source that's presenting the product. And that was where the ACCLAIM acronym that Hannah was talking about comes in. And at the end of the day, if your product actually modified the disease process rather than just stop the pain, now you're on to something. I think. Now, this is my judgment. So that would be ideal. And what has come to market, actually, and this has been literally 35 years in development. It's actually been in the regulatory arena in terms of being developed for clinical use for about 10 years, is an injection of a radionuclide or a radiotherapeutic. And we sometimes take caution and say, well, this is a so-called isotope. There's radiation here. And I would say, yes, absolutely. And that is where a arm of advanced medicine is progressing to. If you have, if you're a male with prostatic cancer, chances are that your physician is going to recommend that they put radiation seeds in your prostate. That is probably the most embraced treatment protocol for treating prostatic cancer these days. So anyway, with that background, this is a product that is a, and I'm going to use a couple big terms here. It is a colloid. So this is a fluid that has these really tiny particles, and it also has been manufactured, this liquid, of these particles, that it's got a little radioisotope that clings to it. And this radioisotope is a emitting radiation of tin, T-I-N, tin. That's the same kind of tin can that you take your baked beans out of, kind of tin. And so this is a radioactive tin that is in this little particle. And you see this little particle in the bottom left-hand graphic there, that little white ball with the buds on it, if you will, being the radioisotope. So what happens is this is injected into the joint, and these macrophages, which we have talked about, that basically they're the carpet cleaners of your joint space. If they see something that they recognize as being foreign, they gobble it up, just like a Pac-Man. And that process is called phagocytation. So it sees this particle that has got this radionuclide that's attached to it. It consumes it, it gobbles it up. And then this macrophage, as a result of the radiation that is emitted, undergoes a process called apoptosis. That's a big old word that means explode. And so I think of it as this macrophage, which is the housekeeper of your joint, consumes this particle. It explodes like it ate a hand grenade. And the important thing here is not that so much that it destroys the macrophage, but it destroys the pro-inflammatory mediators that this macrophage makes. So in destroying the macrophage, it destroys a lot of those cytokines that we saw in the earlier illustration inside the joint that contribute to all of this inflammation that's going on in the joint. So it's an injection. It finds its way into the deeper levels of the lining of the joint, causing these macrophages to explode and therefore suppress that cycle of inflammation.
Mm-hmm. Which, I'm going to leave that go, to come back. Don't you just find that crazy? Like, seriously, I'm just going to step out of being sensible. When I heard about this, I was just like, this is crazy development. And I can remember a few people I'd worked with thought I was crazy to be so obsessed with arthritis. And it's just non-steroidals, huh? It's just non-steroidals. And I was reading this thinking, oh my God, this is such a progressive field. We've got new drugs coming out. We've got completely new therapeutic options with the monoclonal antibodies. We've got this completely new gameplay. This is totally, totally new. We've also got advancements in our diagnostic imaging. We've got musculoskeletal ultrasound, CT. We've got better ways of objective monitoring. We've got our force plate analysis, our gait analysis. We've got advancements in our clinical metrology instruments. We've got COAST that's just come out recently. It's an area of huge development. So don't ever tell me that arthritis is boring. It's extraordinarily exciting. And what is great is it reflects immediately back on our owners. And they really do start to have options, because I know most people that watch this love their dog as much as I loved my dog. And it is so hard to manage this disease long term. So I only had to do it for 3 years. And I didn't go on holiday, I didn't go out. I was permanently trying to support my dog. And having these interventions, knowing that there were things being developed, would have given me a lot of comfort. So, sorry to just get distracted, but I just had to say that, because I do find a lot of people think that OA is, oh, it's really quite boring, it's quite predictable, we just put them on a non-steroidal. Not so. Would you like to add anything to that?
Well, Hannah, I would say one other point to note, certainly within the profession, it helps connect the dots of specialization. Here's a product that people like myself have worked on, know pretty well, and could suggest that may or may not be appropriate for the patient. However, it's not for every patient. This is for some dogs, not for other dogs. And so now the question is, how do we train the veterinarian that you see, that I see with my pets, to help select the right clients and to direct them to this treatment modality if it looks like it may fit their individual pet. It also now embraces also the radiologist, who, as you said, have greater technical skills available to them through scintigraphy and ultrasonography and so forth. It is an opportunity for many of the specialists within our profession to come together to address a ghastly disease, which ultimately in all mammals, if you live long enough, you are going to have osteoarthritis. It's just part of nature.
Yeah, exactly. And there are some clinics that are actually becoming very arthritis focused. And a big shout out to Kristen Kirby-Shaw over in America, who her clinic, her surgery, so she's an orthopedic surgeon with also a rehab specialism. I know that she's already beginning to use this, isn't she, alongside shockwave therapy, alongside stem cells, PRP, HA, alongside physiotherapy, hydrotherapy, massage therapy, laser therapy. Her clinic is, come on, arthritic patients, we've got it covered. And that is beginning to happen here in the UK. Referral centres are beginning to stock more interventions, which is really exciting, because, as you say, I just find it totally bizarre that we don't have more specialised clinics or branches of clinics with a total focus on this disease, because it makes everybody happy, doesn't it? You know, I get to use my skills and what I've trained for. The dog's getting better, the owner's happier, everybody's a winner. Anyway.
Hannah, I would be remiss if I didn't say just one or two other points, which is, if you saw on that list there, compliance is always an issue. For example, if you're taking non-steroidals or giving those to your pets, particularly if you're giving them twice a day, that is a huge encumbrance on busy people. This particular modality is a one-time injection that effect lasts for a full year. And it's those kinds of advancements that it's a win-win for people. If you think of it in that regards, for the veterinarian who can prescribe something that, if the right pet is being administered, gives them a greater confidence in what they can suggest. It is convenient for the pet owner, and the pet benefits. So those are the kinds of areas. Now, this product, again, it's not for every pet. It's not for every pet owner. But to address those kinds of issues that are beyond just the pet, but are also assisting how we can best accommodate to the pet's needs, is an area that is worth considering as well.
Definitely.
Yeah, I've got to say, it's not available outside the United States presently. So for those listeners who are intrigued, and I certainly am intrigued, It's not presently available outside the US, but it is.
No, it was very sneaky of me, because I feel that it's good to know about how the whole industry is changing, the developments that are being made. I find I get almost personally offended when people say, oh, well, you go to the vet, all they're going to do is give you a non-steroidal. No, actually, you go to the vet and say, hey, look, I know that there's a number of interventions out there. Obviously, not this one because it's not available over here. Give them the opportunity to give you choice. The problem with vets is we quite often look at you, walk in the room, see what you want, kind of try and second guess where you want to go with your treatment. If you went to the vet and said, right, I know that there's a number of interventions that I could go and explore for my dog. Let's talk about what I'm suitable for. And then that vet's in a position to say, right, okay, so this is where the arthritis is. These joints are, progressed. This is the options that you have for this. Do you see what I mean? Whereas I think currently a lot of people just go to the vets and the vet almost hand is forced into just choosing a standard intervention. It's complex. Both sides of the table need to kind of have better conversations. He's gone. Anyway, I'm nearly finished. And it's gin and tonic time for me. So I've got a couple of questions here from people. With regards to Synergism in OA, is it easy to answer for whom is it suitable? All stages of OA.
Now, it is like any disease. The earlier you diagnose it and the earlier you treat it, the greater are going to be the end results and ramifications, the attributes of treating early. And I think that it's not as a last choice for dogs. So it would be for that dog that's in the earlier stages of diagnosis, where particularly they've found inappropriate response to other treatment modalities, such as what we've mentioned, maybe the NSAIDs and some of the adjuncts and so forth. So it is, and it might be more appropriate to some people who do not have the luxury of treatments multiple times a day. So you can kind of go down a checklist like there and see if it fits you, if it fits your pet, but it is not a panacea for the dog that's crippled.
Okay, we got a question. Somebody was asking about glucosamine. Which salt was the one in theory, according to some literature, was preferable?
I'm going to give you my opinion. And that's not because I've done any comparative studies, because I have not, and nor have I seen any. However, I'm led to believe through what I read that the sulfate component of the salt is more effective. And I'd have to check my credibility. I thought that in many of the European countries, the sulfate salt was a drug. Now in this country, hydrochloride is not, that salt is not a drug. It's a nutraceutical.
I can remember a few years back when I just started getting obsessed with arthritis, there was definitely people saying that hydrochloride is more likely to be absorbed. But then I can remember reading around a little bit in the human market, and they were saying the polar opposite. They were saying glucosamine sulfate is where more clinical evidence sits. And I just ended up going, oh my God, here we go again. It's just confusing.
Well, that brings to the point that a lot of studies on a lot of these kinds of products have so many variables in design, interpretation, metrics of assessment, numbers of dogs in the study and so forth, that it's therein difficult, or metrics of assessment and the mode or the way the study is conducted, that it's difficult to have enough dogs in one study to make a judgment as contrasted to a different study. And for that reason, oftentimes you just have to look at what there is and say, okay, it satisfies me, but statistically, the highest bar may not meet that criteria.
No. And I think this is a really good opportunity for me to say something that is quite outlandish. we cater for people of all financial backgrounds on here. That was why CAM was set up. We wanted to inspire people that maybe did have insurance or the capabilities to pursue new avenues, but we also wanted to make sure we gave foundational, strong, supportive advice for people that are potentially struggling on a budget, whatever. If you feel that you are struggling to afford a supplement, my hand on heart, get your dog's weight down, get your exercise right, have a meeting with a physiotherapist, learn some therapeutic exercise, maybe some massage techniques, go to your vets, get an intervention for pain that is required. And if that supplement is breaking your bank, I personally deep down feel that's okay. Concentrate on other things. Am I a bit outrageous to say that?
No, I'd say you're exactly spot on. And toward that end, there are those who give, we talked about omega-3 fatty acids, who spend a lot on those supplements. Why would you spend additional money on those supplements when they're integrated into the dog food? Unless the dog food is cost prohibitive, that include that. And I think, again, Hills has shown that just a minor amount of terms of, let me place another term. If you were supplementing with omega-3 fatty acids, you have to give a massive amount to be equal to what is included in their diet. So if those don't weigh up one against the other, obviously you do what you can afford. But you're exactly right. What does it cost you to go out and walk your dog? Just your time.
I really do. Yeah. I really believe that. And N=1 is a very poor study, but I can honestly say, looking after Holly, I learned a lot, and keeping her active, keeping her brain active, doing the exercises, keeping her warm, not letting her jump down from, stairs, beds, and into the back of the car. All of these things added up. They were all little marginal gains that made a really solid management plan. And I think people just get obsessed about purchasing and popping pills. And I think, look at your dog. And for your information, guys, if you look at NICE guidelines for humans, there's very little attention paid to the supplements and stuff. People with their own arthritis are really taught about get your lifestyle right, get your education right, get your weight under control. These are really, really imperative and going to offer way more value than you finding a random supplement that's got brilliant marketing online. Anyway, guys, this is the book that you need to go and buy. This amazing man has written this. There is another book which is even more amazing, hugely intimidating, called This That Is Not Bedtime Reading. This is cup of tea reading. You could get away with a cup of tea or a gin and tonic. This is get a new career. This is hard. Anyway.
One word at a time.
Yes, very. I am so grateful for you giving us your time. It really is an honor to have had you with us tonight. And I hope that everybody has appreciated this, because this guy is busy. But please say your thank yous. I want to say a massive thank you, and have a massively wonderful, beautiful white Christmas, because it sounds like you're going to get one.
Well, thanks to all, and certainly for the privilege of your time. I've enjoyed sharing things. That's what I'm all about. So thank you, Hannah, so very much. And everybody have a happy holiday.
Cool. See you later, guys.